Well, good afternoon and welcome to this webinar, which is Initial Experiences and Outcomes of Laser Retinopexy with Navilas 577S Navigated Retinal Laser. My name is Phil Evans. I'm the product specialist for Navilas in the UK, and I'm happy to see so many people online today. During this live webinar, you will learn how to perform an optimal retinopexy treatment with a navigated laser. An introduction to the concept of navigated retinal laser will be followed by a description of the technique and parameters used for optimal results. A few cases will be shown to demonstrate planning, layout, effective intensities and outcomes, and the presentation will last about 15 to 20 minutes. I'm happy to welcome today's presenter, Dr. Paritosh Shah. Dr. Shah is one of the early adopters of Navilas system in the UK. He is a Fellow of the Royal College of Ophthalmology and a Master of Surgery in Ophthalmology. He has a Medical Retinal Fellowship at Moorfields Eye Hospital, focusing on diabetic retinopathy, macular degeneration, and ocular inflammation. He also has fellowships in vitreo-retinal surgery from Mainz, Germany, and the LV Prasad Eye Institute, India. Currently, he is Consultant Ophthalmologist in the NHS at Yeovil District Hospital Foundation Trust. But today he will share his experience of how to perform an optimal retinopexy treatment with a navigated laser. His short presentation will be followed by a question and answer session. To type in and send your questions, please use the chat window of the webinar application. We will answer as many questions as possible during the Q&A session, and any remaining questions not fully covered today will be answered offline after the webinar. So don't worry if your question hasn't been selected, nothing will be missed. But now let's get started with the presentation, and it's over to you, Dr. Shah.
Hello and good afternoon. As Phil has just outlined, today's webinar is about techniques and outcomes of laser retinopexy using the Navilas 577S, which is a navigated laser system with a built-in fundus camera. It delivers a 577 nanometer wavelength yellow laser capable of conventional continuous wave and microsecond pulsing. Treatment with contact lenses can help deliver ultra-wide field pan-retinal photocoagulation. Focal macular laser is done by a non-contact lens, and more recently, non-contact treatment is now available for pan-retinal photocoagulation as well. The main advantages are that one can pre-plan the treatment for both focal and peripheral applications. The software keeps an entire record of the treatment plan and post-treatment picture. So this helps with standardized treatment process where one can use prior multimodal images to plan treatment, deliver navigated treatment, and keep a digital documentation of the entire process. This is a case with a peripheral retinal tear with lattice degeneration. Before planning the actual treatment, we have put down a few caution zones. The live image is used to plan the treatment with 3 contiguous rows of laser spots. As shown here, the treatment plan is seen directly on the live infrared image at the same time as well. The laser settings are adjusted and a few initial laser burns are applied. A snapshot is taken to assess the intensity of the laser reaction. The power is adjusted further, and once it is satisfactory, the full treatment is then carried out. This is a zoomed in video of the actual treatment area, and one can see that alternate spots are treated. And this final picture taken at the end of treatment is very clearly shows the laser reaction around the retinal tear. The next example is of treatment done with the newer non-contact pan-retinal photocoagulation wide field lens. The procedure is the same as before, with the treatment planned on the live image. So the live image is taken, and then the treatment is planned while the patient sits back comfortably after the caution zones are placed on the image. The software recognizes the location as soon as the live image comes into focus. As shown before, the laser reaction is assessed after a few initial spots, and then treatment completed once one is satisfied that the laser reaction is adequate. This is a completely unedited video of the actual treatment, and we can see that the treatment is very fast, with a total time taken of just over about 1.5 minutes. So these are a few examples of before and after treatment for retinal tears. One can also use the fundus camera image, as shown in this example, for planning treatment if the retinal tear is not very clear on the live image on the Navilas itself. This again shows how the treatment was planned and how the laser reaction looks 2 weeks after the treatment. Very nicely, uniformly spaced, near contiguous burns around the area of the tear. The third case is an interesting myopic patient who was treated for retinal tear about 2 weeks previously. When she came back for a review, she was found to have another retinal tear adjacent to the previous one. The laser reaction around the previously treated tear is clearly seen to be well developed, and the fresh laser burns are seen around the new tear. So we have now treated about 59 eyes over the last 20 months. None of the patients treated with Navilas had a retinal detachment due to the tear which had been treated. One patient has a superior retinal tear lasered, but developed a retinal detachment later due to a new inferior retinal tear. No retreatment with any other method was required in any of the other cases. There were 2 eyes where the tears could not be visualized on Navilas and needed treatment with indentation with an indirect ophthalmoscope. So navigated laser treatment provides increased precision by pre-planning and eye tracking. The patients are more comfortable as infrared illumination can be used. Contact-free treatment is now possible, and in our experience, the treatment time was short with an average of about 1.2 minutes per tear, providing maximum comfort for the patient and the physician. So I would like to share with you a few tips and tricks to help get the best results. The patient should be positioned comfortably, and instilling anesthetic drops in both eyes reduces discomfort. When using a contact lens, tilting the lens can sometimes give a better image of the far periphery. And sometimes retinal tears are difficult to visualize on color image, especially in a pale fundus. As can be seen in this image, the same area is then better seen with infrared illumination. It is suggested and recommended that caution zone should always be placed to avoid inadvertent treatment of the wrong area. But caution zones, at least 2 in number, allows for better tracking during the treatment itself. Switching to color if tracking is difficult, especially in eyes with hazy media, also allows for easier registration and tracking. It is important to keep the eye moist during treatment when using the contactless method. And like with other situations with laser, short pulse duration of the laser is more comfortable than longer pulse durations. In conclusion, Navilas, in our experience, offers excellent treatment choice for treating retinal breaks with good visualization in most cases. Non-contact PRP lens can safely be used if the break is not extremely peripheral. The results are comparable to any conventional non-navigated slit lamp delivered laser retinopexy, but with better comfort, speed, and precision. It is also ideal for teaching trainees as reaction intensity and treatment area can be visualized directly and precisely in real time without having to swap positions at the slit lamp. Thank you for your attention.
Well, thank you, Dr. Shah. That was a clear and detailed presentation. Thank you very much. We'll now move on to our question and answer session. Just as a reminder, to type in and send your questions, please use your chat window of the webinar application. We'll try to answer as many questions as possible. If your question wasn't answered today, we'll do that offline after the meeting. So, Dr. Shah, are you ready to answer the first question?
Yes.
Okay. So the first question is, how much time does the additional step of planning the treatment take? And do you see a time benefit using Navilas as compared to the slit lamp?
Yes, it does take a little bit of additional time. The steepest learning curve is for planning the treatment because this is a new way of working. But once we are comfortable with it, like we showed in the presentation, it does not take very long to plan the treatment, and the precision and the speed of the actual treatment that pre-planning allows for is definitely makes that time well spent.
Fine, thank you. Another question is, for what reason were the two tears that could not be visualized in the far periphery? Did you try to treat them with a 3-mirror lens or on a slit lamp or with an LIO before deciding what to do?
Well, both of these patients were pseudophakic, and there was some peripheral capsular opacification, which made it difficult to localize the tears on the slit lamp. It was possible to see the tears with an indirect ophthalmoscope with indentation. Hence, we decided to go for treatment with cryopexy with indentation.
Okay. We have another one. What is the difference in the effect of visualization between Navilas and the slit lamp? How do the two images compare?
I think that is a really good question, and the biggest difference is that the image on the Navilas screen is a two-dimensional image compared to a stereoscopic view on the slit lamp. However, we know that not all slit lamp delivered lasers always allow for as good a stereoscopic view as the examination slit lamp in the clinic room, for example. But this potential disadvantage is more than compensated for by the fact that we get a wide field view on the Navilas and not a narrow view of the part of the retina on the slit lamp. The much wider view also allows us to plan our treatment precisely.
Okay.
The other difference is that we have to change the way we maneuver the machine, because the image is not inverted or laterally inversed, and hence we have to change our way in which we move the joystick in order to focus the image.
Fine, okay. Another question is, what do you appreciate the planning or pre-planning and the navigation for? How do you use it? Where's the advantage for you?
I think the two biggest advantages are the precision and the speed of treatment. Once the treatment is planned on the multimodal image, which can be, because there is no time pressure, the patient can sit back comfortably and we can plan the treatment on the live image. And once this is overlapped, once the multimodal images are overlapped on the live image, there is no other guesswork involved as to which area needs to be treated. I think that is what I really appreciate about it.
Splendid. We've got time just for one more question, and that is, I've heard that using the Navilas in the far periphery is complex and difficult. Do all your team members use Navilas for focal and peripheral applications?
Yes, Navilas is the only laser machine we use for retinal lasers in our unit, and precise peripheral treatment with Navilas is definitely possible. The only times we have not been able to use Navilas are for patients in whom the peripheral retina was difficult to view even on the slit lamp.
Splendid. Well, thank you very much, Dr. Shah. That was an interesting presentation and discussion. I enjoyed following the webinar today and hope our audience feels the same. We will inform everyone when the on-demand version of the webinar will be available. But in the meantime, if you're interested in more clinical experience and webinars with navigated lasers, please visit our website forum at www.od-os.com/experts. And thank you all very much indeed for your attendance, and hopefully see you soon. Goodbye.